For a long time, heart disease was something we associated with age, a condition that showed up later in life after decades of accumulated risk. But that picture is clearly changing. Across cities, across demographies, we are seeing a noticeable shift. More and more cases of coronary artery disease or CAD are now being diagnosed in people in their 30s, 40s, and early 50s. And it's raising an important question. What exactly has changed? Today's webinar focuses on a topic that is becoming increasingly difficult to ignore: the growing incidence of coronary artery diseases, CAD as we call it, among younger individuals. This session is part of the Treatment Zaruri Hai initiative, which aims to encourage timely medical attention and reduce the tendency to delay care. The idea is simple: better awareness leads to earlier action, and earlier action can significantly improve outcomes. Today, I have with me a panel of experts. Dr. Hasmukh Gujar, Interventional Cardiologist, Poona Hospital, Pune. Dr. Ajit Kumar Jadhav, Associate Professor, Department of Cardiology, D.Y. Patil College, Pune. Dr. Akshay, Interventional Cardiologist, Manipal, Pune. And Dr. Naresh Munot, Interventional Cardiologist, Apollo Hospitals, Pune. Welcome, doctors. Thank you for giving us your very precious time. Dr. Gujar, let me start with you. I'll be honest, post COVID, we were anyway in a very fragile state of body and mind. But now, what's even scarier is that the numbers coming from leading organizations such as ICMR or other health bodies are putting Indians at a very high risk. And it's not just the data, but reality too, where we are seeing people in our own friends and family circles having heart related crises at a very young age. What actually has changed in the last 10 years to be causing this? It can't be just one pandemic alone. It has to be much more than that. I think everybody is asking that question now.
Yeah, definitely. Definitely, what you said is absolutely right. Post COVID, we have seen a lot of increase in coronary disease in India, specifically all over the world, specifically in India. There are many reasons for that, not just the pandemic, not just the vaccination. One thing is India has become a leading cause of death. This coronary disease in India, it's an epidemic, and the most important things are urbanization of the maybe most of there are less villages and more urbanization now, sedentary lifestyle, unhealthy eating habits, unhealthy sleeping patterns, and maybe more addictions. These are the additional risk factors which have been contributed to more incidence of coronary disease, which specifically hits the bread earner, and it's about 5 to 10 years earlier in India as compared to Western. So definitely, it's on rise, and an awareness is required to control it.
Dr. Jadhav, we are looking at Indians only as more prone to developing CAD at a very younger age compared to Western populations. And the numbers have always been international database. So, we have always had markers that are more appropriately suited to them. We have had more research happening around them. Is one of the reasons why we are not able to figure why the younger in India are at a high risk compared to the Western populations? Are we different than the markers that are around us, really?
Absolutely. As Dr. Gujar has already told us about the genetic predisposition in these younger population, as well as in Indians, we do have a lean diabetics with the higher visceral fat. So high inflammatory markers, high oxidative stress, bad sleeping habits, excessive stress at work. So everything has put together, causing this younger population, IT crowd, to more and more defer development of coronary artery disease. And those patients are presenting to us without any obvious symptoms of coronary artery disease. That's the main problem.
That's an interesting thing you say that sedentary lifestyle is causing a lot of complications when it comes to health. But Dr. Kashid, how easy or difficult is it to get out of this vicious cycle? Because lifestyle factors are only contributing to the numbers, not just CAD, but other lifestyle diseases. You know, now we have autoimmune diseases, we have diabetes, we have so many other things that are cropping up, and lifestyle still becomes a factor of our environment. And a lot of us are struggling to fight with that. Having said that, which are the most top three factors that you see are contributing to the trends of CAD in a younger population?
So Dr. Jadhav correctly mentioned that it is the genetic predisposition which really aggravates the risk factors. But in addition to that, these conditions is definitely triggered with lifestyle related problems. That in recent era we have literally witnessed that there is definite change in the lifestyle. All of us are having going through the race of a competition related to increase in the or development of anxiety, changes in the lifestyle, improper sleeping habits, faulty diets, and related lifestyle risk factors like smoking or other addictions, which definitely contribute. Now, only talking about the prevention aspect, we really require to modify these risk factors to curtail down the ultimate development of a disease. So, for example, the heart problems, as I said, it comes with a big bang noise, but the risk factors whisper into your ears. So that's why if you can timely identify those risk factors and try to modulate or modify these risk factors, then we can reduce the ultimate development of a diseases, or at least the severity of the diseases, or timely identification of these risk factors can definitely avoid the development of a complications of risk factors.
Fair enough. And it also makes sense when we talk about prevention is better than cure. But a lot of times, Dr. Manoj, it so happens that a lot of people miss the signs. Sometimes the signs are confusing. Sometimes you feel it like it's, you know, it's a gym injury, or sometimes you are feeling that it is just the stress of everyday work. Everybody is stressing over lifestyle changes that are induced by work and life. But when we talk about the early warning signs, what are those where we should completely take a call and say, okay, I could be at risk?
So people often tend to confuse between chest pain of acidity versus cardiac chest pain, and at times they just label it as muscular pain and tend to ignore these symptoms. The usual
Mm.
symptoms of heart disease, firstly, we have chest pain or a heaviness which the patient describes right in the middle of the chest, which may be confused with acidity. Also, there may be some shortness of breath, breathlessness while walking or while climbing stairs. And then there are some patients who may complain of pain radiating to the arm, either of the arms, or jaw, or to the back. Sometimes symptoms such as unexplained dyspnea or even sweating or nausea can also be a presenting sign of a heart disease. So, early recognition can definitely help the patients to seek medical attention promptly and to prevent severe complications.
Dr. Gujar, in the moment of uncertainty, if someone suspects they may be having a heart attack, what should they immediately do? What are the first critical steps? Because we always speak about the golden hour. And as Dr. Manoj said, that some of the risk factors, some of those signs, once we see and once we suspect, what should be our first goal? Reaching the hospital or doing something at home? What should we be doing?
So this is a very important aspect of maybe myocardial infarction or heart attack, and should be discussed in detail, because many patients we see they come to doctor, that they come to hospital very late. Once the muscle damage is there, once they have got a massive heart attack, once they have got the low blood pressure or heart rate which is very low or very high, then they come to hospital. It's too late at that time. So if any person has got symptoms of maybe suggestive of heart attack or retrocerebral chest pain or burning or severe sweating, as Dr. Munot has said, severe sweating, or any different symptom from the usual, maybe an epigastric pain, pain in abdomen or pain in jaw or pain in the shoulder, you first get an electrocardiogram done, ECG done. If you have these symptoms at home or in office, just try to tell your colleague that you have got symptoms of some suggestive of heart attack or suggestive of cardiac chest pain. Call for help. Just don't sit and take some drink some water and call for help first, because that is important, because a person next to you is going to take care of you. So that is important thing. Loosen your clothes. You just lie down on the flat surface or maybe on a couch or on table. Call for help, and if possible, go to the nearest hospital which is there, maybe a clinic hospital, and get an electrocardiogram done. By that time, you can do a rhythmic cuffing, loosen your clothes. You can go to open space, but try to seek medical help as early as possible. If you are in near some medical shop or in some hospital where you can get first aid, there are blood thinner medicines, blood thinner tablets like aspirin. You can take it immediately if you have got that medicine, so that you can abort an heart attack. So all these basic things should be done, and a person should know that he has got symptoms of heart attack and he should approach to someone rather than just sitting and waiting that let I should I go to home and then we'll in the evening we'll go to doctor and then take ECG. Just call you for help and get the things done immediately.
Dr. Gujar, you interestingly mentioned that one should be able to critically understand that you need to get to a hospital in time. But when we are talking about intervention, when we are looking at, sometimes, a lot of times, it so happens that the symptoms have been showing themselves from a few days.
Yeah.
And it could be 2 or 3 days in a row that you are having mild pain or mild discomfort, and then it grows into a situation. When should we be looking at addressing these repetitive symptoms, which may appear mild but are there?
Yeah, these symptoms are very common. Usually, these is symptoms in maybe middle age or old age, and the person has got mild symptoms. Just keep on doing his activities, keep on working, and the symptoms aggravate because of exertion. So even if these mild symptoms are warning of a big heart attack or a massive heart problem. So with these minor symptoms, he should rush to his family physician or his cardiologist or his doctor and insist the doctor to take an electrocardiogram and do further tests, so that he should not miss on a heart problem or major blockage in the heart. So if he goes to the clinic, he should insist the doctor. Sometimes the doctor may say that it's an acidity and I'm seeing you since many days and I don't think so it's heart. But insist that to get an electrocardiogram done, and further test, like we have got a blood test which can we detect a heart attack on a blood test, or a 2D color Doppler from which we can detect a heart attack. All these advanced tests need to be done to 100% show that it is a cardiac thing or non-cardiac thing. If we suspect a cardiac thing, then definitely there are some blood tests, a troponin test, which will show even a minor heart attack can be seen on the blood test. Apart from the electrocardiogram, there are new routine tests, which is 2D color Doppler of the heart, in which we can definitely see a heart attack if it is a major one, and then take care accordingly. So
I think what's
investigations
most
are very
important, yeah,
important
yeah.
for diagnosing of heart attack. And once we see that the blood test is positive and 2D core and electrocardiogram is showing some changes, then we need to assure the patient that don't worry, don't take tension, we are with you. We have to rush to a nearby hospital or give some medicines on the emergency basis in our OPD or office, and then take him into confidence and then act accordingly.
I think it's also so important that one should have awareness about the doctor, uh, the hospital which is the closest. Uh,
Mm.
how will I reach the hospital if I'm all by myself? What is the ambulance service number?
Mm.
Is there someone in my building or in my office who can drive me? I think that kind of preparedness should be there in everyone. And I think now they are saying that if you have a genetic predisposition in the family,
Definitely.
if you feel that your earlier generations have struggled with the coronary artery diseases, then you should also have like a medication kit that you are talking about, which can completely address. So I think there's a lot of prep that is required to meet a calamity if it strikes. But having said
Maybe,
that, given that a large proportion of heart diseases are considered preventable, and effective lifestyle changes are only to be adopted, realistically, Dr. Jadhav, what are we looking at? Because a lot of people say, थोड़ी cigarette smoke करता हूँ, weekend पे drink करता हूँ. A lot of your women also say, no, I managed to sleep. I managed to get my sleep over the weekends. But what are some of those lifestyle changes that realistically should be adopted as a non-negotiable?
Absolutely. These are very simple steps which we can inculcate it daily in our life. So most important thing will be maintaining a healthy diet. That means it should be containing of a low carbohydrate, high protein, high fiber, which includes the high quantity of your fruits and vegetables. The moderation of alcohol as well as quitting the smoking is very important. Second thing, we should absolutely try and go for a regular exercise pattern, which is like going for around 75 minutes per week, a moderate to high intensity, as well as a 150 minutes per week, a moderate intensity workout should be planned so that it is very easier for to manage a healthy weight on the go.
Hmm.
And also stress at the workplace should also be managed well. So these are the important things. Along with that, a regular screening is important. Also control your
Yeah.
blood pressure, blood cholesterol levels, as well as blood sugar levels.
Right. Dr. Kashid, the diagnosis, as we were talking about now, has also evolved significantly. Could you walk us through how CAD is typically identified today and how early we are now able to detect it?
So as Dr. Jadhav correctly said, screening helps a lot. So the screening examination involves the basic blood investigations like your cholesterol levels, what we call lipid profile, the marker of lipid profile, then sugar levels, the fasting sugar, random blood sugars, HbA1c or the average 3 monthly sugars. Along with that, the particular cardiac test involves simple ECG. Now, it is not necessary that ECG should be done when we get some symptoms or chest pain. The routine evaluation or routine screening with ECG can also help to identify certain abnormalities which are ongoing. Addition to that, if we find something abnormal with the ECG, we can go ahead with the sonography of the heart, what we call as a 2D echocardiogram. And along with that, the functional assessment of the heart or indirectly any further development of any blockages inside the coronary vessels and the capacity of the heart and lung can be assessed with the stress test or the treadmill test. Now, this routine evaluation definitely identify any underlying pre-existing or ongoing conditions and can timely evaluate for the development of a future diseases. Along with that, those individuals which may be having minimal or no symptoms, but they may be having the strong family history, and if these individuals undergo some screening evaluation, if find some abnormal parameters, then we can suggest the option of a new test called as a CT coronary angiography. This is a non-invasive test, but it really helps a lot to identify any abnormality inside the blood vessels of the heart or any minor or major blockages which may go silent, but they can be dangerous in the future. So these are the basic tests which we should advise the individuals.
Dr. Kashid, when we talk about tests, we are also talking about the the markers that India is using at the moment. And most of the markers that we had were borrowed from the West. And a lot of times it's very easy for somebody to say, it's a fatty liver, but every Indian has it. It is insulin resistance is something else which is not prescribed in your packages that you take for health. And it's not the test that really comes when you are doing your fasting sugar in those packages that the hospitals give. Are there some definite tests that we should be doing, irrespective of what is being said and sold, as these are the markers that you should be looking at? And do you feel that Indian markers are also going through a change now?
Yes, definitely, because till now the battery of investigations used to imply just the basic markers which are helpful for the identification of the risk factors. But nowadays there are certain novel risk factor identifiable markers which are introduced and they really help a lot. Some of them to mention include lipoprotein small a, other risk factors like high sensitive CRP levels. Other risk factors includes ApoB by A1 ratio. So these are certain markers which can definitely identify whether we have strong risk factors or no. If these markers remain normal, then there is definitely minimal chance. Now, the recent guideline from the American Heart Association, which they have put forth for the cholesterol levels and cholesterol updates, they have clearly mentioned the introduction of these markers routinely into the Indian population, or at least those individuals who are having the strong risk factors for the development of a heart diseases.
Noted, sir. Dr. Manoj, there is still a lot of confusion between a heart attack and a cardiac arrest. And a lot of times people do not understand that they are completely different. But what, in simple terms, can the definition be?
So, as you correctly said, most of the times people confuse heart attack with cardiac arrest. So, heart attack basically occurs when the blood flow to the heart muscle is blocked due to a clot in the coronary artery. So, there is some cholesterol plaque, or maybe there is some blood clot or thrombus which has been formed, which has blocked the blood flow to the heart, which leads to some damage or death of the heart muscle. This is heart attack. Cardiac arrest, on the other side, occurs when the heart will suddenly stop beating due to some electrical malfunction. So heart attack can lead to a cardiac arrest, but also suppose maybe kidney failure can lead to a cardiac arrest, or lung disease can lead to a cardiac arrest. For example, during COVID, many people would die because of a cardiac arrest. That did not mean that people had a heart attack because of COVID. So after COVID, there were some chemicals released in the body because of severe lung disease and extensive involvement of the lung, which would suddenly affect the heart and which could lead to a cardiac arrest. Sometimes there is some poison which is there in the blood, some metabolic issue, which can again lead to a cardiac arrest. So in simple terms, heart attack is a circulation problem, but cardiac arrest is an electrical problem where the heart has stopped beating, which can be because of a heart attack, but may not be also because of a heart attack. Yeah.
But you know what is interesting, Dr. Manoj, that a lot of times there are people who have reached the emergency room and have been told that, hey, this was your second heart attack, or this was your third heart attack. How does that happen? How did it go unnoticed? And by the time they reach and they realize that they are now dealing with the magnitude, it was already damage that was done before, which they had no idea about.
So many times people are ignorant of their symptoms. So a person with diabetes might have some chest pain or might just have a feeling of acidity, and he might not
Mm.
realize that it's a heart attack because the pain might not be so severe. This usually happens because of numbness of the nerves. So the pain sensation is numb. The person might not feel the pain of a heart attack. He might just feel there is some heaviness, some vague pain in his chest, which he might attribute to acidity, and there the
Mhm.
heart attack goes unnoticed. After a few days he might just start feeling normal and he may develop some breathlessness because one heart attack has occurred, some muscle has been damaged, and now there is some breathlessness. Another few months down the line, another heart attack in another artery of the heart, that could lead to a second heart attack, and this time the breathlessness is worse, and this is why the patient comes to the hospital. And in the hospital, when the doctor sees the ECG, he sees that the ECG is showing some heart muscle damage in one area of the heart. At the same time, there is some fresh damage or fresh ischemia to another area of the heart. So he would say that, there are probably two heart attacks, and this is your second heart attack. And at times, there is a test called the 2D echo test, the ultrasound of the heart, which will help us diagnose such cases. So there might be a scar or a dead muscle, dead myocardium, dead heart muscle on one side, which will suggest that there was a previous old heart attack, say a few months ago or a few years ago. And then there is a fresh hypokinesia or decreased heart muscle movement, which suggests that there is a recent heart attack on the other side. So the doctor might just say, you've got two heart attacks or three, this is the third heart attack. And then the heart
Mhm.
pumping is also severely decreased. So that puts the
Right.
person more at risk. There is a higher cardiac risk. Yeah.
Dr. Manoj, just adding to this question, are the markers different for men and women? And I often wonder that are the tests also then different for men and women? Should women be doing prioritizing stress test or 2D echo, or there's a treadmill test, and usually they give you an option between the two at the hospital when you're going for your diagnosis, and you're wondering, yeah, but I run in the gym, so I can do this test, or you don't know which one to pick. So, anything that you can shed light on there?
A very logical and a very real life scenario question. So most of these health checkup packages, they usually give an option of either choosing the stress test or the 2D echo. In an ideal case scenario, you should be doing both. But then because of certain cost constraints or some cost cutting, the company where somebody is working, whichever company somebody is working with, they might say you choose either one of the two. So in such a case, what we usually do is, in younger people, you can just do a simple 2D echo test, because the echo test will help us to detect cardiac malformations. Maybe there's a hole in the heart, maybe there's some structural abnormality. And in the elderly people, somebody who might be having some chest pain on exertion, the stress test might be more fruitful. It might give us more information, because the stress test is the test which actually diagnoses blockages, whereas the 2D echo is a structural test. The stress test is a functional test. So given the choice, I would rather prefer a stress test if my previous 2D echoes were normal. And if I have never done a 2D echo before, then maybe doing a 2D echo because it's the first time, maybe I would like to know the structural condition of the heart. And then later on, next year or the next year, I would just go for the stress test directly. So if the ECG is all right, then the stress test is good. And the second part of the question, you asked me whether the males and the females have different markers. So to be very honest, CPKMB, troponin T, troponin I, all these markers are more or less similar. The cutoffs are also the same. There are no separate cutoffs defined. But then the stress test can have more false positives in females. Even in the ECG, the routine ECG, there are some leads V1 and V2 which may show false T inversions in females because of the breast tissue. The nurse might just attach the ECGs lower down or higher up, and that's why the ECG may show some abnormalities. So we usually tend to ignore certain ECG changes in females as compared to males. Another thing is about, there's a test called stress thallium, or a myocardial perfusion imaging test. In this test, sometimes because of the breast shadow, there might be a false positive test when the person who is interpreting the image, he might interpret it as a positive stress thallium or a stress technetium test, just because there was a breast shadow and the uptake of the tracer was not seen clearly. So these are the subtle differences which we should be aware of, but then more or less the major cardiac markers are the same.
Yeah, jumping onto the treatment side of it, Dr. Gujar, when it comes to treatment and when we look at angioplasty, that is often the first term people hear. How would you explain what it involves? A lot of people feel angioplasty is similar to bypass surgery, or sometimes the doctor says on when we are doing angioplasty, we will do the intervention. So there are a lot of pieces that are different in the treatment. Could you explain those?
Yeah, definitely. See, once we diagnose that patient has got some heart problem by doing all the necessary blood test and then electrocardiogram, 2D cochlear Doppler, stress test, then if the patient has got cardiac symptoms, in most of the patients who are younger or got cardiac neurosis, we say that your stress test is normal. You don't need to do any further test.
Right.
That's all. It was with the stress test. If the stress test shows some problem or is electrocardiogram, 2D echo, color Doppler, or patient has got classical symptoms of heart, blockages, maybe angina. It is called as angina. That is pain in the chest while walking and all that. So the patient has got classical symptoms of heart blockages or has got a myocardial infarction or heart attack. Then the diagnostic test is coronary angiography. Coronary angiography means the we visualize the arteries of the heart which supplies the heart. Because in heart attack, as we have discussed, in heart attack we get a clot in the vessels of the heart, and then there is a 100% block, and then we get a heart attack. So we do a coronary angiography, a normal invasive coronary angiography, percutaneous coronary angiography, what it is called. Normally it was done some 1 decade back from the leg artery, femoral artery. Now we can do from now hand artery, radial artery, maybe from the right or left side. So it's an
Right.
invasive thing. Angiography takes 10 to 15 minutes. It's a diagnostic test in which we see the blockages. We confirm the patient has got blockages or no blockages. Okay. If the patient has got heart attack, then probably he has got an 100% block in one of the three arteries of the heart. We have got our heart has got three main arteries, two on the left side, one on the right side. Left anterior descending, left circumflex on the left side, and right coronary artery on the right side of the heart, supplying the right side of the
Hmm.
heart. So any one of the three arteries can get blockages. It may be 100%, it may be 90%, it may be 50% also. Once we do the angiography, we come to know the blockages, and then we discuss with the relatives. If the blockages are more than 70%, then they usually cause symptoms from the blockages, and then we tell them to fix it by doing angioplasty. Or maybe if there are many blockages and there are a lot of calcium and very critical, then we can suggest them bypass surgery after doing angiography. There's always a fear in the patient's mind that once a doctor does angiography, he's going to do angioplasty.
Yeah.
Not always. It is not always. See, if the patient usually why we do angiography, because the patient has got symptoms. So definitely there's going to be something in his heart vessels, in his coronaries. That is for sure.
Hmm.
Sometimes if it is false positive, as we have discussed, if the stress test is false positive and we have done
Hmm.
angiography, it can be normal. But in the typical cardiac myocardial infarction or heart attack patient, or in diabetic patients who has got typical symptoms of heart attack or of angina, usually we get blockages to see in the coronary arteries. If the blockages is more than 70%, what we say, if the
Right.
blockages are less, more than 70%, then we advise them to do either get angioplasty done or a bypass surgery done. If the blockages are less than 70%, then we usually manage them with medicine.
Yeah.
This is the basic thing.
Hmm.
And then further there are a lot of things in the sense, if patient has got blockages of more than 70%, and if the cardiologist or a person is expert, then we can proceed further by doing angioplasty, by discussing with the relatives the pros and cons of the angioplasty, the types of angioplasties, and the further course of action what is needed.
Right. Doctor, one question always comes, which is, should angiography be a elective test to do after a certain age? A lot of countries we see where angiography, colonoscopy has been advised as a mandatory test for people over a certain age. In India, do you think we should also have angiography, if made affordable to everybody? At what age should one by choice also go and get one done?
Yeah, good question. Because many of the patients or persons ask, should we get angiography done? If the person has got a strong family history, in the sense he has got early deaths in his family, maybe a parents or a brother, sister who has got early deaths, or has got dyslipidemia, his cholesterol is abnormal, cholesterol is persistently high, has got diabetes or hypertension, definitely he should get himself evaluated by, we have got a non-invasive test. But after this routine test, a stress test and all, we can get a CT coronary angiography done. It is a non-invasive test in which we put a small needle and do the angiography. It is usually done in the CT scan department. And from the CT coronary angiography, we can definitely know whether patients needs aggressive treatment, if it is angiography is normal or abnormal. Depending on that, we can treat that mild blockages which we see on CT coronary angiography aggressively. We can tell the patient to control his diabetes, blood pressure, or give cholesterol medicine to prevent further increase in the blockages. So I think that definitely a person who has got abnormal cholesterol, diabetes, and blood pressure should electively get an CT coronary angiography done for risk stratification. In patients who have got high risk or strong family history, should be done maybe by 35 or 40 years of age, should do his CT coronary angiography, and then every 3 to 5 years to see whether the blockages are still same or they have increased.
Interesting. So you're saying, sir, that if you have a predisposition with family history, then as early as perhaps 35, 40, and if you are seeing your markers go up and down or out of the range, then we are looking at anytime after 45 years of age that you should be getting your angiography.
Definitely. You should get it. Maybe CT,
And
not a CT coronary angiography, not a normal invasive angiography. Maybe
right.
a CT coronary angiography should be a routine.
Dr. Jadhav, if I may get you in here. Now we're talking about advancements in technology, and one of the things that people talk about is stent technology. What has changed with newer drug-eluting stents, and how have the outcomes improved? Because a lot of people, when they were talking about stents, they were looking at stents also as invasive and as mentally traumatic as perhaps what would have happened in a major heart surgery. But now that narrative is changing, we hear so many people who are now opening up to talk about their comfortability in talking about stents, etc. And it's so common now. So how has that changed over a period of time?
Definitely, as we are going into this advancement in the stent technology, we do have an improved polymer coated stents as well as ultra thin strut stents, and we do also have a longer stents available to cover the entire length of the blockages. So all these advancements in the newer drug-eluting stents are just not improving the long-term outcomes, but it also improves the re-narrowing or a restenosis or a stent thrombosis like complications or a target vessel failure kind of a complications. So these stents are definitely coming with the improved outcomes, and along with that there are some other things like a bioabsorbable scaffold, or nowadays we are not using a stents, we are using a stentless angioplasty, which is called as drug coated balloons. So these are also
Right.
been utilized in this newer advancement.
Let me just now break all of these bit by bit. Dr. Kashid, I'll come to you for this metal-less angioplasty that is being spoken about. And what does that mean in practicable terms? And how is it changing treatment option for patients uh, practically when you are at the floor and seeing people?
So, taking ahead this discussion, nowadays the stentless angioplasty or the drug-coated balloon angioplasty is into the market. Now, earlier the drug-coated balloon angioplasty was introduced just for the angioplasty of a small vessels. For example, the vessel size is less than 2 millimeter. For example, there are the blockages present in the side branch where the stent deployment is not possible, or during the stent deployment there is definite chance of injury over the blood vessels. So nowadays that plan is getting shifted towards the introduction of a drug-coated balloon even for a vessels of a larger size. The advantage is that patient is happier that he does not have a stent inside. Number two, there is something called as a maintenance of a vasoreactivity of a vessels. For example, if we deploy a stent, then there is a metal scaffold over the blood vessel. It loses the vasoreactivity. Now, if there is a drug-coated balloon, we just paint the vessel from inside with the drug and we remove the balloon. So there is no stent or no metal scaffold inside, and the vessel maintains its patency. So this is the advancement in the angioplasty technique, in which even we can go for the angioplasty of a larger size vessels. For example, sometimes there is a critical blockages of a bifurcation regions, in which we have to go ahead with a stent deployment in one larger blood vessels, but there is definitely another blood vessels which is nearby passing with a large blockages, in which sometimes it is difficult to deploy another stent, and there is definitely chance of a side branch compromise or the metal jacket. In such techniques, even with the deployment of a drug-coated balloon, we can preserve that vessel, and as well as we can treat that vessel. Another thing is nowadays there is something called as a bioabsorbable stent, in which we deploy a stent, and over the period of time, it is a metal-less, just polymer eluting drug, in which the scaffold gets removed and the vessel again maintains its patency and the vasoreactivity. So these are the newer advancement in techniques in which we can treat the patients with a certain modification in the angioplasty.
But to taking a leaf from there, I do want to discuss a little more about the bioresorbable scaffolds because they sound interesting and they don't stay in the body permanently. Could you explain us the advantages that they offer? And when you are meeting a doctor and when you are given all of these options, how do you know how to go about researching, how to find about what is the best fit for you? Because you're a layperson who may not have an idea about it.
So the bioresorbable scaffolds or the BRS, they temporarily support the artery and they gradually dissolve within the next 2 to 3 or 2 to 4 years, and they restore the artery's natural function, but they totally disappear, leaving no permanent metal behind. So it's a very good idea, and if we select the patients carefully, they are really really good stents if we are selecting the patients correctly. So, as I said, the selection.
Could you elaborate on the bit where you're saying if we choose the patients correctly? Does that mean not everybody is a perfect prototype for this treatment?
Correct, correct. So previously, when BRSs were the bioresorbable scaffolds were used, so it was recommended that they are best used in vessels between 2.5 millimeter to 4 millimeter in size, and they are ideal for simple lesions, some simple blockages, and complex blockages would not do as well. Like if there is a bifurcation lesion, if there is heavy calcification, so these patients will not do well with absorbable scaffolds, because the calcium will probably bring back the blockage. Even if the stent will dissolve, the calcium will bring back the blockage and that will bring the problem back again. So these patients don't do well. Heavy calcification, complex lesions, bifurcations, and very small arteries bigger than 4 or smaller than 2.5 not a good idea to use these absorbable scaffolds, especially in arteries below to very small vessels which are less than 2.5 millimeters in size. So we should avoid that. Another thing is about the length of the blockages. So if the length of the blockage is below 24 millimeter, then it is a good idea to use the stent and it has better results. However, the stents are available in sizes up to 48 millimeters. But then in the study, the inclusion criteria was mainly for shorter lengths. So that's a better
Understood.
choice.
Understood. Dr. Gujar, we were talking about drug-coated balloons as well that are being used in certain cases. While we did discuss what are they, could you tell us why a cardiologist would prefer them over a stent?
Definitely, as already we have discussed, to maintain the integrity of the vessel, the functionality of the vessel. If you put a stent, it's a rigid thing.
Hmm.
So the it can hamper the contractility of the maybe vessel and hemodynamics sometime. In that cases, we drug eluting balloons or drug coated balloons is a good development. In the last few years we are using it, maybe 2 to 3 years we are using it. A lot of trials with drug eluting balloon now. Specifically, a drug-eluting balloon, the drug is embedded in the balloon. It's coated with the balloon. The balloon is coated with the drug, and that balloon we take into the coronary artery and inflate for a longer time, maybe 30 seconds to 1 minute. We inflate the balloon so that the drug which is coated to the balloon get delivers into the vessel wall, in the coronary vessel, and then we remove the balloon again. It prevents the restenosis. In a smaller vessel, if we try to put the stent, there are high chances that the stent might get blocked later, or
Yes.
the vessel size is less than 2 millimeters. In that cases, still the vessel is important, and in that case, we are not able to put a stent. So these drug balloons are important. And again, if we have a stent in place, then the person has to take medicines for lifelong. He has to take blood thinner
Yeah,
medicines for lifelong. And again, the chances of blocking the stent or restenosis of the stents are high. So instead of giving a metal, give a drug which is directly delivered into the vessel. That is the main idea
right.
behind it. And in some cases in which the stent develops instant restenosis. Sometimes even if you put the best stents and multiple stents, one of the stent might get
Right.
blocked because there's some intimal hyperplasia of the vessel wall and the stent gets blocked. In that case, putting another stent is not a good idea. In such cases, these drug-eluting balloons, drug-coated balloons, are definitely very helpful to us, so that restenosis again is prevented in these vessels.
Makes sense. Dr. Jadhav, the question now, after all of this, is given all these big options, DES, BRS, DCB, how do you decide what is best for a particular patient? What factors guide that decision? Also, is there an age criteria? Is there a comorbidity criteria? Is there a longevity of treatments, efficacy criteria? What are the things that come together when you're making a decision like that?
See, as a cardiologist, whenever we are choosing amongst either drug-eluting balloon, whether drug-eluting stent, or the BRS or the bioresorbable scaffold, the characteristics usually depends on the patient risk profile as well. Along with that, the lesion characteristics, like how critical the block is, how calcific or how tortuous is the vessel, what is the vessel size where we are putting it. Many a times it is always a combination approach which is we are using it, such as a bigger vessel may get a drug eluting stent, and a smaller branch of it, or a distal vessel where which is a diffusely diseased vessel, where we can put a drug coated balloon. So
Right.
the importance of delivery of that drug to that distal part of the vessel is to prevent the further complications or the long term difficulties for those patients. So it's always a combination approach. It's doesn't always mean like this for this kind of a patient. We use a combination approach.
Noted, sir. Dr. Kashid, when we are talking about prevention, there are our demography in the country is roughly at the age of 28. That's the maximum population. There also is a big population that is now growing up with all kind of lifestyle diseases. For the young viewers who are watching us, who may feel this is still a very distant risk, what should they start doing today so that they avoid a heart disease later in life?
So, as we already discussed, heart diseases is no longer a disease of senior citizens, and age is no more a criteria. Now, we have really witnessed that almost 50% of angioplasties are below the age of 40 years of age, thanks to the faulty lifestyles and multiple risk factors combined together. So, as we said, the prevention is always better than the cure. So, risk modification strategies are always helpful and they are best possible answer. So, in that, the first of all, as we all know, that in urban population, the difficult lifestyles or the faulty lifestyles is one of the culprit reason for the development of diseases. So, modification of the risk factors. Now, it includes start inculcating the healthy lifestyles like have a proper sleep, then go for the good physical activities, at least as Dr. Jadhav mentioned that 150 minutes of moderate intensity exercises in a week, or 180 to 210 minutes of mild to moderate intensity exercises in a week in a divided portions is very important. Then whatever, however, is the stress factors, whatever, however, is the rat race, always keep the anxiety and the stress levels at a bare minimum level. Don't bring all the stress and anxiety to the home when you come from the office, because it actively and passively involves your family members also. Then, because of the stress levels, we are prone for other addictions and smoking. Nowadays, there is a for the IT population there is a work from home job, which involves that while काम करते करते चलो let's have some faulty diet, let's have some chips. Let's have multiple teas and coffee. Let's have a beer at the night time. So these are certain difficult lifestyle trends which we are following needs to be stopped immediately. Then there are some individuals which develop heart diseases at a really younger age. They definitely have some family history, strong family history, like paternal side, the grandfathers and father. The grandfather, there is a history of a sudden cardiac death, or the father might have undergone multiple angioplasties. So these individuals, even they are maintaining their lifestyle, should undergo routine annual health evaluation. Dr. Munod said that the corporate health checkups involve either of echo and TMT, but it's better always to undergo all the three basic tests like ECG, 2D echo, and TMT. And as you already discussed about the CT coronary angiography, those individuals in which those siblings or the parents have undergone the or they have witnessed the heart problems, they should undergo CT calcium score or CT coronary angiography once in at least 3 or 5 years, so that we can get a fair idea about any possible blockages inside, minor or major blockages, and we can rightly answer them, address them with some introduction of blood thinners or lipid lowering agents, etc. Definitely, the risk factors include diabetes, hypertension, thyroid, and other diseases. These are not the diseases; these are the risk factors. But timely prevention and control of these risk factors definitely will avoid or postpone the development of the heart problems, which is really important. Sleep is something which is really underestimated. Now, those IT population may have the US clients and they have to stay awake overnight, and it brings a lot of addictions. So, if possible, I always mention them to change the job straight away if they really have developed some risk factors or they really have strong family history. So, we should have a proper sleep, at least for 6 to 7 hours of a sleep, which is considered sound sleep, is really important. So again, the talking about the diet which is rich in fiber, low fat, high protein diet is really helpful. We should have a healthy breakfast, uh, moderate amount of a lunch, and a minimum quantity of a dinner before sunset or before 7 p.m. It really helps. So these are certain simple ways of a lifestyle which we really inculcate. Then it can really avoid development of a heart disease.
Kashid, there's a bunch of things that you have asked everyone to do, and I don't know how many people are actually able to do that because they keep thinking about it. That we'll start the healthy eating from tomorrow, we'll start the exercise from tomorrow. The gyms have all the memberships full in January, and by March, everybody is out of those gyms. I think that's one of the reason why these regular health checkups become very important. And Dr. Manoj, I would want you to tell us a little more about the health checkup and where it fits. What should be the age? Secondly, that when it becomes non-negotiable, and I always talk about the women, the women health from perimenopause to menopause, and there is a lot of change in your body and at a lot of times the symptoms you feel are like can be easily mistaken for any other disease. So how does one look at those? And apart from that, is there anything else that you would like to talk to us about when we talk about health checkups?
So the regular health checkups, they help us identify silent risk factors such as high cholesterol or hypertension or early plaque buildup, which helps us to do timely intervention and prevent heart attacks. So very simple and basic investigations like doing a lipid profile, a sugar test, a random sugar test, or a HbA1c test, and just going and getting your blood pressure checked. These are very simple and very basic investigations and tests to be done, which should be done at least once a year starting the age of 30 or 35, which will help us diagnose the silent risk factors in time and prevent heart attacks. So if in case somebody has been found to have, say, high cholesterol or high blood pressure, then it can be monitored, and if necessary, then treatment can be started. This will help to decrease his cardiac risk. Usually these ignored risk factors, they build up over time, and then they suddenly lead to a massive catastrophe or some major heart attack or something, and the person lands in the hospital and he's like, no, Doctor Sahab, I never had any problem. He probably had
True.
it, he never got himself checked, and it was ignored. So we need to be more proactive with our health checkups. Now, regarding the age at which we should start doing the health checkups, so previously
Yeah.
we would say that beyond the age of 45 you should get yourself checked at least once a year, annual health checkups. But now that is gone, that era is gone. People, younger and younger people, are having cardiac problems, especially in the
Right.
post COVID era. And with the increasing number of smokers and youngsters, all these addictions, tobacco use, smoking, and whatnot. So we
True.
have to be more proactive for the younger individuals also. Even most IT companies, they want all their employees to get themselves checked once a year. So we recommend our patients to get themselves checked once a year after the age of 30. Even before that, if there is a strong family history, for example, somebody's got a family history of young heart attacks, so this person will have to get himself checked beyond the age of 20 or 25. Somebody with something called hypertrophic cardiomyopathy, which is one of the important causes of sudden cardiac death. So if he has a child who is 16, 17 years old also, we'll ask him to get a 2D echo test done. So if there is some particular risk factor or some very strong hereditary risk, so we have to start even earlier, but the usual age is somewhere around 30 years. Then another question which you asked me was about the perimenopausal age group. So this is something really confusing. Most females, when their periods are becoming infrequent, and at this age around 44, 45, 47, this age group, they start having sweating episodes, uneasiness, some chest heaviness, and then they feel whether मेरे को कुछ हो रहा है क्या. Now there are
Correct.
two aspects. Yeah, so now there are two aspects to this. Sometimes once menopause sets in, not sometimes, as in every time, once menopause sets in, the risk of heart disease in females will equal to that of males. So before menopause, in a regularly menstruating female, her cardiac risk is significantly less as compared to females. Traditionally, it was considered to be significantly less, though it still is, and the risk is increased in females, but it's still less as compared to males. But if
Understood.
in the post menopause, the risk is significantly higher. So one thing that it could definitely be something cardiac, and second thing, it could just be the hormonal changes which is causing hot flushes. So we have to be very careful about this. Get a routine evaluation done, get a ECG, echo, and stress test done. Do good counseling. Maybe ask her to see a gynecologist who can maybe give
Right.
some multivitamins, sometimes hormonal pills, and that usually take cares of it. In rare cases, when this is extreme and the patient keeps coming back to us again and again, then we have to recommend to do something like a CT, coronary angiography or something. But most of the time, this is benign, though we definitely have to be vigilant. Yeah.
Thank you,
Okay.
doctor. Thank you for that.
Thank
Finally,
you.
just one message that all your doctors would like to give to our viewers today about protecting their heart and health. Given that they are living in a very fast-paced world, there is an onslaught of social media, there is an onslaught of lifestyle changes that are coming with what they are seeing. But if there was one advice you could give,
Okay, so a simple lifestyle changes like eating pattern, changes in eating pattern, like as I already discussed, with the low carbohydrate, high protein, high fiber diet,
right?
managing work stress, decreasing alcohol intake, as well as improving, uh, keeping the healthy weight alongside the keeping a healthy BMI, and regular health screening will definitely try to improvise your health, as well as it also prevents the long-term complications, and significantly improve, also decreases the risk of development of coronary artery disease, and improve your quality of life.
So, one thing that you would want to tell our viewers to take away from today's discussion about protecting their heart and health.
See, basically, prevention is better than cure. We all know that. So, against these small steps, what we have discussed is an regular exercise and healthy diet, adequate sleep, de-addictions. These all these things are very important, and de-stressing. There are many trials and articles which also says that socializing, you work hard, you socialize also. If you have good family and friends, you be with your family, with your friends. If you socialize, definitely the stress buster, it will reduce the incidence of heart attack or cardiac events. That is also very important. Regular exercise, regular screening. What I say to my patient that the patient comes to us and he says that a B blood test here. We have done blood test now 6 months back, and it's already
Mm.
3 years back. So we tell the patient to do your the blood test and screenings once you have done with your birthday every year. Once you finish your birthday, in the next week you get your done screen. Maybe with the all the tests and maybe 2D ECG, electrocardiogram, 2D color occurrence test. So that once we have done our birthday party and then in the next week you do your screening. So that every year it reminds us that we should get it done now. So these things are important, and one of the
So
main
very
important thing is and medical insurance. It's an need of the hour because any treatment in an hospital is costly. So most of the patients we see that they don't take treatment or fear to go to hospital because of cost, fear of cost. So again, medical insurance is very important. We should have at least insurance of minimum of 10 lakhs, 15 lakhs, or more than that, maybe 10 lakhs minimum. Sometimes patient comes to us that we have got insurance and its amount just 50,000, 1 lakh, which is of very minimal, less use. Any cardiac treatment nowadays is quite costly. And so I tell my patient if they don't have insurance, get it done. So that definitely they will be helpful. It will be helpful to them. So it will not be a burden to the family. That's
right.
important.
Fair point. That was actually a very good point made, sir.
Mm.
Dr. Kashid.
So the one advice I would like to mention here is if you develop some symptoms, so just don't test your body because most of the symptoms land in a gray zone. We are not sure whether these are simple atypical symptoms or whether it is really the beginning of your heart attack. So it costs nothing to just walk down to the hospital and do simple 400 rupees ECG, but it can really save your life. So if you develop some symptoms, just visit a nearby clinic or cardiologist if possible and evaluate yourself.
Noted. Dr. Manoj, you have the last word.
Definitely. So, last but not the least, most important of all, rather, I would say, I would like to emphasize on prevention. So, heart health should be a priority, and small lifestyle changes like regular exercise, healthy eating, stress management, periodic health screening, everything can significantly reduce the risk of CAD, and it can improve the overall quality of life. So, prevention is definitely better than cure, and small lifestyle changes make a big impact.
Thank you, doctors, for giving us your time and for this wonderful conversation that we are having today. And I hope this is as informative for our audiences as it has been for me. Thank you so much. What this conversation makes clear is that heart disease is no longer a distant risk, but it's a present reality. But the encouraging part is this: many of the biggest risk factors are within our control. Awareness, early detection, and small, consistent lifestyle choices can go a long way in protecting our heart health. To our viewers, this is one area where prevention truly is more powerful than cure. So stay informed, stay mindful, and take care of your heart.